Alright, this is going to be Chapter 4, Fluid and Electrolytes and IV Therapy. And introduction here, maintaining a proper balance of fluid and electrolytes within the body is necessary for life. It is important to be familiar with the basics of bodily fluids and electrolytes. This chapter reviews the basics of fluid, electrolytes, and acid-base balance. This chapter also describes some commonly used intravenous fluids and their roles in the treatment of fluid and electrolyte compromise. Distribution of water, total body weight and total body water. 60% of your body is water. Largest component is the intracellular fluid. Extracellular fluid is about 15%, and that would be outside the cell, intervascular or within the blood, and interstitial or outside the blood but not within the cell. And sometimes that's kind of hard to picture, so if we're talking about a cell and we're talking about a vessel, intervascular fluid would be here. And then interstitial fluid would be fluid in this space here. Outside the cell, but not in the vascular space. Intracellular fluid, 45%. Most fluid is within the intercellular membrane, and is considered fluid within the membrane. Intracellular fluid, 45% here. Let's change this one. That would be fluid that is inside the actual cells. Fluid distribution. So we have intercellular 45%, and this is overall your total body weight. Interstitial fluids about 10.5%, and intervascular fluids about 4.5%. Electrolytes. An electrolyte is a substance that, when placed in water, separates into an electrical charged particle called an ion. A cation is positively charged, and an anion is negatively charged. We actually measure electrolytes in something called milliequivalents. A milliequivalent is a concentration of electrolytes in a certain volume of solution based on a number of available ionic changes. In practice, electrolytes are given as milliequivalents per liter as in intravenous solution. So whenever we look at these or we're given an actual electrolyte, it's going to be in milliequivalents. Example of this would be sodium bicarbonate. The dosing of sodium bicarbonate is 1 milliequivalent per kilogram, so 100 kilogram patients would require 100 milliequivalents of sodium bicarbonate. Major cations. We have calcium, magnesium, potassium, and sodium. Calcium is required for bone growth, metabolism, big player in blood clotting, normal cardiac function. The calcium rushes into the cell in the middle of the cycle, so it elongates the contraction, and initiation of any neuromuscular contraction. So calcium is released at neuromuscular junctions to initiate the contraction. Magnesium, required for body temperature regulation, protein and carbohydrate metabolism, and neuromuscular contraction. If you want to think about calcium and magnesium as kind of working the opposite sides of the teeter-totter, so CaMg, those kind of trying to balance one another out, as well as sodium and potassium. Now, potassium is responsible for acid-base regulation, muscle excitability, and nerve impulses. And sodium is a major extracellular cation, positively charged. All of these are positively charged. Responsible for fluid balance. Sodium levels rise and water is retained. Also preserve the balance between calcium and potassium. Major anions, bicarbonate being the one major buffer of the body. We use bicarbonate as the bicarbonate buffer system in the body. Kidney produces it, makes it available, picks up hydrogen ion, dissociates down into CO2 and water. Chloride, major extracellular anion, main function is to maintain fluid balance, along with sodium chloride. Phosphate, major intracellular ion, helps maintain acid-base balance. Fluid transport, normal metabolism requirements. We require passive transport, and we're going to come up with some terms and explain these. Filtration, diffusion, and osmosis is what we're going to explain. Pharmacologists think of intracellular and extracellular fluid as occupying two compartments, or they're actually in separate compartments. There's an intracellular compartment and there's an extracellular compartment. And the fluid movement or the fluid transport is what occurs between those two compartments, since we have a semi-permeable membrane. Now, we'll explain this more later, but I'm going to try to kind of drop it or seed it all right now. So this is filtration, and filtration means that whenever we place a substance into the extracellular space, there's a large quantity of this blue stuff at this point. Now on this side, all of this space here really has fluid in it, or water. So very simply, it goes from an area of higher concentration to an area of lower concentration, and vice versa. On this side of it, this is side A and side B here. On side B, we have a higher concentration of water. So the water is going to move that direction, and then I'm going to use black for the other one. The solute is going to move in this direction. So by the time that we're done, which is down here, we have equal parts on both sides of this membrane, and all it did was try to equalize. And this is what filtration is: the movement of fluid through a membrane caused by the differences in hydrostatic pressure. Two compartments separated by a permeable or semi-permeable membrane, hydrostatic pressure causes the fluid to move from one compartment to the other until the pressure is equal in both compartments. For the movement of this blue stuff going this direction, there has to be channels for it to come across, or it will not move. Osmosis versus diffusion. Osmosis is the net movement of water from an area of low solute concentration, and sometimes we get this confused whenever we hear the word solute. Solute means the solid substances, or the blue in that slide that we just saw. So a low solute concentration and a concentration to an area of higher solute concentration. So all we're saying is osmosis, from its perspective, and this is kind of the reverse verbiage of this, that it moves from an area of low solute concentration, but to its perspective it would be from a higher concentration of water to a lower concentration of water. So it moves from a lower solute concentration to a higher solute concentration. Diffusion is the net movement of solutes from an area of higher solute concentration to an area of lower solute concentration. So we're talking about this from the perspective of the solutes. Facilitated diffusion is diffusion that moves solutes with the use of helper proteins across the membrane. An example of this is going to be insulin. Active transport is the movement of solutes from an area of higher concentration to an area of lower concentration across the membrane with the use of energy. So sodium-potassium pump would be examples of this. Facilitated diffusion would be insulin. Diffusion would be just the movement of anything that would have channels from an area of higher concentration to an area of lower concentration. So if I had a semi-permeable membrane and I had 4 solid substances over here and 2 solid substances over here, by the time that I got done with this, it would be 3 on both sides. And I'm going to erase this one. This one moved over. To balance this concentration, this would be diffusion, area of higher concentration to an area of lower concentration. On this, osmosis. The osmosis is just the movement of water. It's the diffusion of water. So if I had the same parts over here, 2, 3, 4, 5, 6, the water would move this direction. The solutes would move this direction. So solvents is the red, solutes would be the green. So diffusion, this is the last graphic on it, and we're going to talk about this, the green and blue. So the blue is going to move very simply in this direction, and this is going to take time. So it doesn't happen immediately, but it'll start its movement, if we'll see here, until it is equal on both sides, and vice versa. The water, to the water's perspective, this is water, and then this is actual solutes, and we can actually say UTES, and clear that. Yeah, let's just clear the whole thing. Give me a second here. This is solutes. This is a solvent. So, very simply, from an area of higher concentration to an area of lower concentration, and vice versa. The blue devices, or the blue solutes, are going to move from an area of higher concentration to an area of lower concentration. So both of them are going to do exactly the same thing, but we're looking at it from the solute or the solvent's perspective. Active transport. Active transport, very simply, is a way of powering something and changing the electricity so that we can formulate an action potential. An example of this is a sodium-potassium pump is initiated so that the heart has the ability to contract. This does require ATP molecules to change the formation of this channel, gated channel, on the surface of the phospholipid bilayer. Acid-base balance. Chemistry and metabolism maintain equilibrium through acidity and alkalinity of the bodily fluid. Bodily fluid's potential of hydrogen, or pH, is the most frequently used tool to assess acid-base balance. The pH is measured inversely, which means it is measured backwards of what you would think it would be. On the next slide we'll show this more, but if you have a pH of 2.0, you are super acidic. That would be like stomach acid acidic. If you had a pH of 14, that would be super alkalotic, or like lye, bleach, things like that are alkalotic. They break down fats. This would cause necrosis of the tissue, the 2.0, and this would cause saponification of the tissue, or cause it to formulate into soap. Grandma, if everyone will remember this, Grandma made lye soap by putting fat renderings in with lye. Well, lye is super alkalotic. So pH, we only live at a certain specific level. pH is 7.35 to 7.45. The PaCO2, or the amount of CO2, is measured in 35 to 45 millimeters of mercury. And the HCO3, or the bicarbonate level, normal levels are 21 to 28 milliequivalents per liter. Again, that is an electrolyte, and we measure it in milliequivalents per liter. So in that, whenever we have respiratory acidosis would show us a high concentration of PaCO2, so this would be up or greater than 45, and the pH would be less than 7.35, and this would be normal. So that would be respiratory acidosis. A pH greater or less than 7.35, which would mean they were acidic, and then a PaCO2 that was very high, greater than 45. The next one on our list is respiratory alkalosis. In respiratory alkalosis, we have a pH greater than 7.45, so they're alkalotic. The next thing that we see is a PaCO2 that is less than 35. Both of these are primary. This is the primary assessment tool of that acid-base balance. And again, the bicarbonate levels, or number 3, would be normal. Metabolic acidosis. We have a pH, this is metabolic acidosis. And we have a pH less than 7.35, which would make them acidic. The CO2 level, this one, is going to be normal, or maybe even low. And the low would be compensatory. And then we're going to have an HCO3 that is less than 21 milliequivalents per liter. That's a surefire way of saying I did not have enough bicarbonate to make this happen, and my pH is adjusting, and it has nothing to do with CO2. How we get that is if the CO2 is low, they're trying to breathe it off to compensate for their overall acid-base derangement. Last but not least is metabolic alkalosis, which is going to the pH is going to be greater than 7.45. The PaCO2 is going to be normal. And HCO3 is going to be greater than 28 milliequivalents per liter. Nice easy way of solving acid-base balance with ABGs. Blood pH. This is an inverse logarithmic value. So what that means is we live, or hopefully we live, right at about this range right here. If we are less than this, we are acidic. So numbers like 1, 2, the lesser the number, the more acidic the person is. And the greater the number, the more alkalotic they are. If we're out by 1 point in either direction, it is non-life sustainable. There's inversely things that are relationship here. If we increase our breathing, increase the amount of O2 that we have, we only have a certain piece of pie in our bodies as far as certain specific gases. So as the O2 increases, CO2 decreases. Well, that will cause an alkalosis. More specifically, when it deals with breathing, a respiratory alkalosis. So hyperventilation creates alkalosis, hyperoxia, and hypocapnia, or low CO2 levels. Decreased breathing, whenever we have somebody that's in respiratory arrest, we have a decreased oxygen because we're not ventilating, and an increase in CO2. The hypoventilation causes acidosis, and that's because we get hypercapnia, or large amounts of CO2, and very easily the body can turn that into an acid. CO2 plus water, which we have an ample supply of, is HCO3, which is carbonic acid, or H2CO3, which is carbonic acid. IV therapy. Two indications for IV therapy. One is fluid replacements, and the other one is to provide a route for drug administration. For fluid replacements, signs and symptoms of things like hemorrhage, diarrhea, vomiting, heat exhaustions, or burns is what we would actually replace their fluids for. Two major classes of IV solutions are going to be crystalloids and colloids. The crystalloids is what we primarily use on the truck. Contains only water and electrolytes, readily diffuse across the cell membrane, primary solutions used in pre-hospital IV therapy. They're classified according to their tonicity related to the plasma, and that means their thickness or their thinness. In pre-hospital treatment, fluids are usually based on patients' needs and underlying needs. Replacement fluids are the most commonly isotonic solution. The examples of this would be lactated ringers and normal saline. Common pre-hospital fluids, Hartmann solution or lactated ringer solution, isotonic electrolyte solution that contains sodium chloride, potassium chloride, calcium chloride, sodium lactate, and water. This is non-compatible to the potassium that's in there with blood products. Normal saline, isotonic electrolyte solution containing sodium chloride and water, and this is compatible with blood products. So if they're getting blood, they need to have normal saline. 5% dextrose in water is a slightly hypotonic solution that we use to mix most of our drugs with. The glucose solution is used to keep the vein open for medication administration and creates no change in circulatory volume. But since it is slightly hypotonic, it will have just a little bit of a push into the cellular environment, which makes it kind of fortunate for us. Because if we're trying to hit a receptor site, what that's going to do is it's going to push the medication that's in that fluid right into the cellular compartment where we need it. Colloids, compounds of a high molecular weight, usually proteins, which do not readily diffuse across the cell membrane. They exert colloidal osmotic pressure, which means they tend to attract water in the intravascular space. Usually have a short shelf life and are very expensive. That's why we don't see much of them in EMS. Examples of colloidal solutions: plasma protein fraction, or plasminate, and this is the principal protein in there, is going to be albumin. Salt pore albumin contains only human albumin. Dextran, not a protein, but a large sugar molecule with osmotic properties similar to albumin. Hetastarch, or Hespan, sugar molecule similar to those of a protein, not as many side effects as dextran. Polyglylene or hemicell, a gelatinous colloidal with osmotic properties similar to albumin. Tonicity. We have 3 tonicities that we are worried about, and this is the balance on the fluid. How thick or thin is the fluid? So if it's isotonic in a semi-permeable membrane environment, it'll balance. There will be no net movement of fluid. If it is hypertonic, that means on one side I have something that has a high solute concentration. So what that hypertonic solution is going to do is pull fluid towards it. And hypotonic solution. Matter of fact, in a hypotonic solution, on the other side, in the cellular compartment outside of the vasculature, that is thicker than the actual hypotonic solution. So we get fluid movement in the other direction that rushes into the cell. In conclusion, EMS personnel must be able to recognize and rapidly treat with fluid, electrolytes, and acid-base abnormalities. To replenish fluids and electrolytes, the proper intravenous fluids must be chosen and given at the appropriate rate. To maintain appropriate acid-base limits or correct acid-base abnormalities, you must maintain a patent airway and improve ventilation using 100% oxygen as needed. The most important drug in correcting acid-base abnormalities is oxygen, and that's because we can adjust the amount of CO2 that's in the system and thereby change the overall acid-base derangement. Slides for this references for this come from Beck Pharmacology for EMS Providers, pages 37 through 47 from Delmar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology 7th edition by Prentice Hall. Graphic slide on slide 9 and graphic on slide 12 came from Wikimedia, which were the Diffusion. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@msa.net, or 405-219-7613. Thank you.